Welcome to the 2016 CE offering on hyperdynamic drugs. My name is Steve Cole. I'm with Ada County Paramedics, and as part of our cooperation with the Access System, I hope you'll find this presentation useful. Now, what we've done is we've broken this down into several videos. The first one here is probably going to be the longest one, and it's going to focus on the pathophysiology of hyperdynamic drugs, stimulant drugs in general. And then we'll talk about treatment options in a separate video, and then we'll talk about the individual drugs, moving on past that and some other considerations. So these are our objectives for this course. We're going to talk about the hyperdynamic sympathomimetic toxidrome. We're going to talk about what a toxidrome is if you're not familiar with that term. We're going to then describe and differentiate the following hyperdynamic drugs. We're going to talk about amphetamines. And amphetamines is a broad class that includes methamphetamines, amphetamines, and ecstasy, also known as MDMA. We're going to talk about the synthetic cathinones, what we commonly refer to as bath salts. And we're also going to talk about the cocaine and cocaine derivatives. We're also going to discuss the pitfalls of treatment of the patients under these influence of these drugs. We're going to talk about what I refer to as the lethal H's. We're going to talk about Haldol. We're going to talk about restraint, and we'll also have a little bit on excited delirium that you'll have to participate in. Now, if you know me, you know that I am actually pretty passionate about drugs, about street drugs. You probably have heard me lecture about opioids. You might have heard me lecture about GHB, DXM, PCP, ketamine, etc., etc., so forth. But it's been quite a while since I've done a purely hyperdynamic drug lecture. And that may cause a little misleading impression that there's not much to them. But actually, this is a fascinating class of drugs, broad spectrum of drugs, and we're going to get into that quite a bit. Now, what this means, unfortunately, is that it's going to be real easy for you to check out and say, I'm an EMT basic or advanced EMT. I don't carry benzos. I don't carry Valium, Versed, Haldol. All I know is I'm going to take them to the hospital or help keep them calm till the medics get there. That is that would be a mistake. There is a lot of ALS information in these presentations, but there's a lot of BLS stuff too if you look for it. And I'll do my absolute best to try to keep the BLS stuff up front and pertinent without focusing solely on the ALS stuff. But even at that, there is a lot of anatomy and physiology, especially physiology understanding this. So please try to bear with me and so on and so forth, because I'm telling you, it is pertinent to everybody, regardless of your level, because everybody in our system will encounter a lot of patients under stimulant drugs. We do it every shift, just about. Probably the only drugs we see more often is alcohol. So hopefully I've driven the importance home to you. Now let's talk about a little bit of the pathophysiology now. Pathophysiology is the physiology of the disease or illness, and that's what we're going to focus on rather than just talking about the cardiovascular system or whatever. Now, a lot of times people say, is hyperdynamic drugs, how is that different from stimulants? And it's not really that different. I will use this term probably interchangeably. But I do want to stress that there's a difference between hyperdynamics and sympathomimetics. Now, sympathomimetic drugs are a specific broad class of drugs. Your amphetamines, your cocaines, your cathinones. But a lot of drugs, beyond those, will also have hyperdynamic or stimulant properties. So that's why I like to kind of narrow it down a little bit. A lot of what we talk about here today will be good for the larger category of hyperdynamic crisis. In other words, these patients are in this stimulant overload. Even though the primary drug may not be technically solely a stimulant, it may just have stimulant properties. So I hope you can appreciate that. There are drugs such as PCP. PCP technically is not a stimulant, but it's a dissociative, and it has a lot of times when people go quote unquote berserk under it, they have a stimulant or a hyperdynamic crisis component. And a lot of this stuff will absolutely apply to those patients, even though technically PCP is not a stimulant. So when we talk about this, you're going to hear me talk about the toxidromes, specifically the sympathomimetic toxidrome. Now, sympathomimetic simply means a drug that stimulates the sympathetic system. Now, a toxidrome, I think, what is a toxidrome? Well, if you know what a syndrome is a collection of symptoms that imply a certain disease. The acute coronary syndrome is a collection of symptoms that implies coronary disease, such as chest pain, shortness of breath, diaphoresis, left arm pain, back pain, so on and so forth. Now, you can have chest pain that doesn't have anything to do with cardiac disease. You can have shortness of breath that has nothing to do with cardiac disease, but you combine them together in a certain pattern, it implies you're having a cardiac emergency. That is a acute coronary syndrome. So a toxidrome, bear with me here, a toxidrome is simply a syndrome that relates to a specific toxin instead of a specific disease. So for those of the hazmat and former military, you might remember the abbreviation SLUDGE: salvation, lacrimation, urination, defecation, gastric distress, and emesis. SLUDGE, that's the mnemonic for organophosphate poisoning. That's a toxidrome. So the question is, what are the symptoms of the sympathomimetic toxidrome? Well, it's pretty much what you would expect. And it's pretty consistent across the spectrum of drugs that we're talking about here. So most of the drugs will cause dilated pupils. Most of the drugs will cause decreased sleep, insomnia. Most of them, they're stimulants, so increase your heart rate, increase your blood pressure, increase your body temperature. That's a big one. Because they increase your body temperature and they increase your muscle activity, if you're agitated, they increase CO2 production. And this causes you to become acidotic, usually lactic acidotic over time. Because they do all this, they also increase your oxygen consumption, the amount of oxygen that you're using. And this can cause a relative hypoxia. And I'll talk more about that. So it's not absolute hypoxia. You're still taking in oxygen just like I am and so on and so forth. You're just not taking in enough for the need of your muscles, which are in overdrive, and need of your body, which is in overdrive. So where do the differences come in when we talk about the crosses toxidrome? Well, the route, especially with some of the drugs, the route that you take the drug plays a big role. The onset differs between cocaine versus meth versus bath salts. Some predispose you to more hallucinations. Some make you more manic and paranoia. Some are actually cardiotoxic. Cocaine is cardiotoxic. It actually damages the heart and the coronary blood vessels, where methamphetamine is simply cardiostressful. So it just increases the workload of the heart. And that plays a big role when we talk about actual risk of heart attacks and so on and so forth. Most of them, some of them have a neurotoxic component. Most of these drugs do their stimulatory effects through dopamine. So what they do is they either cause increased dopamine excretion in the brain, or they slow the excretion or reuptake of dopamine in the brain, or both. Most of these stimulants will also cause serotonin excretion or reuptake inhibition. And sometimes a couple of the drugs will even cause epinephrine and norepinephrine excretion and or reuptake inhibition. So depending on which drug we're talking about, these are three major neurochemicals that can cause stimulatory effects. So they either cause more of it to be excreted on your brain, or they cause it to accumulate on your brain because you can't get rid of it quick enough. The result is often the same. It's a stimulant overload, what we commonly cause the sympathomimetic toxidrome. And again, there are some drug-specific flavors, but they have most of this in common. Because of serotonin, most of them will dilate the pupils. If you find constricted pupils in a patient that appears to be in a hyperdynamic crisis, there's something else going on. Maybe it's opioids. Maybe it's not the drug you thought it was. Maybe it's organophosphates and you're in trouble. Maybe it's a head injury, stuff of that nature. Most of them will cause tachycardia. They all will cause cardiac stress, but remember, cocaine in particular is also cardiotoxic. Most of them will cause high blood pressure. This increases the risk of stroke. A couple different types of stroke. Increase the risk of cerebral bleeds, and they can even cause abdominal pain, either through dehydration or they'll cause the intestines to necrose, and that can cause peritonitis, which can be life-threatening. Now, diaphoresis, sweatiness, is tricky. You think, of course, they're sweaty, they're on a stimulant. Well, think of it as a lot like heat stroke. If you find somebody who appears to be in this sympathomimetic, this hyperdynamic crisis, and they're not sweaty, they're dry, that is not a good thing. That's a very bad symptom, just like in heat stroke. And they'll usually be hot and dry. Now, a lot of them will cause paranoia, anxiety, and agitation. Some of them will cause hallucinations, and then that can progress into delirium, and we're going to talk about that in a few minutes. And bruxism. Bruxism is simply grinding of the teeth. It's very common in all the stimulants, so that's always a sign as well. So a big red flag, though, a big pitfall, is just because somebody hands you a methamphetamine or a bath salts case on a silver platter, says this is what he's on, keep an open mind, because other problems can cause stimulant-like behavior. Drug withdrawal is a big one. I will always remember this kid who was in an auto accident and who was bouncing over the place and looked for all the world like a methamphetamine overdose. And he had a history of methamphetamine use, criminal convictions, and I really was 100% sure, and he was tachycardic and hypertensive, that he was a methamphetamine crisis. And the reality of it is he was alcohol withdrawal. I missed some of the, and it was right there in front of me. There were some subtle signs, but I discounted it because I was handed this methamphetamine presentation on a silver platter. So don't be fooled. Keep an open mind. Also, psychosis and behavioral conditions, especially if they're off their meds, can also mimic stimulant use. What will happen is they will become so agitated, they themselves will have a lot of circulating epinephrine and norepinephrine in their system. They'll fight, they'll be very agitated, and they'll cause muscle activity, and often they'll die in a very similar way that a patient who's in a true hyperdynamic crisis will die. But there may not be actual drugs involved. It's purely psychological. But dead is dead at the end of the day. So you need to be very cautious and keep that in mind. Actual delirium. Now, an easy way to think of the difference between delirium and dementia or some other chronic medical condition is delirium is usually an acute change. Dementia is always a diagnosis that takes months to diagnose after everything else has been ruled out. So elderly people can get delirium, so can the very young, and it's usually a very, very bad sign. A lot of things can cause it: brain injuries, closed head trauma, chronic closed head trauma. Again, side effects of medications. I also talked about, again, how a lot of drugs can have stimulant properties even though they aren't specifically stimulants. And the big ones are the dissociatives. And then, of course, other medical conditions as well. Regardless of how they get there to this hyperdynamic crisis, a lot of the things that kill these patients are pretty common across the spectrum. And over the years, I've kind of started calling these the lethal H's. Now, the first three H's you will find also in opioids: hypoxia, too low oxygen, hypercarbia, too much CO2. These two will combine to cause acidosis, H ions. But the one thing that sets stimulants and hyperdynamics apart from, say, the patient who's overdosed on opioids is hyperthermia. You combine hyperthermia with these other three already bad H's, and the mortality skyrockets. Hyperthermia is bad, bad, bad in these patients. And, it's not just hyperthermia, but you combine these four lethal H's, and it's horrible. And when you see these patients that die in custody, that die after the taser or after restraint or so on and so forth, you can usually identify most, if not all, of these 4 H's leading up to the fatal event. So additional complications, sympathomimetic toxicity. It really tends to peak about 1 to 4 hours post ingestion. Although, depending on drug, this can be a lot longer. It's route specific, it's use specific. Obviously, most of the toxic effects you see with either IV use or smoking. IV use has a higher mortality, but not just from the increased intensity of the drug, but from some other specific things we'll talk about. Smoking sympathomimetics, whether it's cocaine or methamphetamine or whatever, has some very peculiar pulmonary considerations, and we'll talk about that, as well as exacerbating asthma and COPD. And of course, the intranasal route can cause mucosal damage. It can also cause all the stuff that you see with IV use with rapid onset. Some other big risk factors. So when you see this, I want big red flags to go off in your head. When you start hearing descriptions of multiple day use, where they've been binging for 1 or 2 or 3 days or 5 days or a week, big red flag. When you see the multiple day use, it tends to really imply, and they're agitated, it seems to really imply an increased risk of delirium, agitation, and those 4 H's I just talked about. When you hear how they've been unable to sleep, that usually implies they've been using it for multiple days. And again, the same risk, as well as the same risk of agitation. And one other big thing, and we're going to show a video later on of several prone restraints, and one particularly that things went horribly wrong. But this is a big thing. Do not restrain these patients prone. You may find them prone, but turn them on the side, facilitate the respiration, facilitate getting rid of the carbon dioxide, facilitate increased oxygen intake, and that will correct acidosis, and then hopefully that will help correct the hyperthermia as well. Now here's another street tip with these hyperdynamic patients: nakedness. When you find a patient who's taken off his shirt, when he's naked and agitated, it's not always a sympathomimetic toxin, but it really implies hyperdynamic crisis. Now I've got 2 pictures here. Now I want to point out this guy on the left he's standing there, he's calm, he's interactive. Now he's naked, but he's just standing there, and he's making a point. He's actually protesting, kind of being just a little bit of a butthead to the TSA officers at the airport. He's probably not a hyperdynamic crisis. He's standing there calmly. He may have other issues, but if he is probably not hyperdynamic. However, the guy on the right, he required 4 officers to restrain him. Even with the officers being restrained, he's still struggling. He hasn't gotten the message. And that is a big red flag, because they'll struggle until they absolutely cannot, and then that's usually paramortem or pre-cardiac arrest at that point. And I got a great video to show that later on this presentation. Another big concern with all your hyperdynamic drugs is hyperdynamic drugs in pregnancy. The use of stimulants, methamphetamine, bath salts, cocaine, whatever it is, predisposes the patient to abrupted placenta, as well as multiple fetal complications once they're born, depending on the specific drug. So if you have a pregnant patient who has been doing cocaine, been doing methamphetamine, ecstasy, bath salts, whatever it is, and they start complaining of abdominal pain, even if they're like only 20 weeks or 30 weeks into the pregnancy, they're definitely preterm. Treat that as a high-risk obstetric patient on top of what you're dealing with. Those patients should go to places with NICU capability. Also consider the environment that you're getting these patients out of. And if there are children in that environment, that is usually a cause of neglect. There's some specific, what they call the drug endangered children um, regulations. I'm not going to go in so much here, other than say that if you find a child in a place where they're cooking meth, where there's a high instance of meth or cocaine or whatever use, get law enforcement involved. It usually constitutes neglect. It's not a safe environment, and that is a form of abuse. Also, keep in mind your own safety as you're wandering through this, through these houses, these residents. There may be chemicals, there may be a meth lab, needles, guns. I mean, you look around this picture I have here, and if you found a patient in this and you're restraining him, you have no idea what's in that debris. He may come out with a screwdriver, a hatchet, a 45. Be very cautious of these environments that you're encountering these patients in. And with that, we're going to close this particular video, and when we return, we'll talk about specific treatment regimens. Thank you.